Good evening, everybody. It's pleasure that Gurudatt sir has accepted our invite that he is going to train the postgraduates of MG and CRI. All of you know that sir is adjunct faculty of Sri Balaji Vidyapeeth University. To tell about sir, his passion is teaching. Sir has been training students for the past 30 years, sir.
Yeah, more than 30 years now.
More than 30 years. And there are faculty and postgraduates who got benefited immensely from sir, and they used to tell me like how they got benefited. Even here, 10 years back, I'm not getting her name, sir. She was a faculty here. She was not CPS, sir. Before that.
Okay.
She was gold medalist from Mysuru or Bangalore. She's working in Bangalore now. Actually, at the time itself, she was saying that she got fascinated about your teachings. So I felt that the postgraduates here should get the benefit out of it. So I requested you, and you graciously accepted. And it's going to make changes in the postgraduates' knowledge component. Thank you too much for that. And with regard to the postgraduates, if at all they do any mistakes, please forgive them and motivate them, sir. That's the only request from my side.
Yeah, definitely.
Shall we start, sir?
Yeah, we will start off.
Yes, Dr. Start.
Just before starting actually the discussion regarding the mitral stenosis of rheumatic origin. So our presenters are actually Dr. Kaushik and Dr. Shruti from Mahatma Gandhi Medical College. So before they present, actually I would like to appreciate Dr. Hemant's effort, because very few head of the departments will take so much of interest as far as the students are concerned. So he's taken really so much of interest. He was asking me for the past so many days. He was telling, so why can't you take some classes and all? Now I think today it has materialized.
Yes,
sir. Wish all the students of MGM should thank Dr. Hemant for this. And now yesterday we were discussing, I think day before yesterday with Dr. Hemant. Now the practical exam marks has been increased to 400. Actually, till now, it was only 300. So 200 for the clinical case presentations and 100 for the Vivos. Now it has been increased to 300 plus 100. So the long case, the marks also has been increased to 120 and short cases 50-50. And I don't know, ASCII also has been introduced 60 marks ASCII plus 20 marks, I think, for your dissertation.
So, for dissertation, sir.
So another 80 marks has been added, but for long case, the marks has been introduced from 100 to 120. So almost, that 220 marks will be there for case presentation. And out of 300 in the morning session, you may have to score about 150. So out of 220 only, you can score more than 150, provided you do very well in your case presentation. So that is the reason why you should prepare yourself very well for the case presentations. Of course, there are limited number of long cases which we are going to keep. Everywhere it is like that only. You will have one respiratory case, one cardiovascular case. You may have a liver case. You may have a kidney disease case, a thyroid case, and a pregnancy pre-eclamptic patient. Usually these are the long cases what we are going to keep. Of course, short cases can be congenital heart disease, and even thyroid can be kept for short cases, the pregnancy, the diabetic foot, even fractures. All those things are usually kept for short cases. That means you will be knowing actually what are the cases that are usually kept. So once you know already what are the normal routine cases that are kept, it's very easy for you to prepare yourself for these cases. What I should tell you is, in the long case, you have to go into details, because you will have about 45 minutes to examine the long case, and I think about 15 minutes to examine the short cases. Long cases, you have to go into details about the history, because for everything marks has been separately split and allotted. Out of 120 marks for long case, everything is given importance, and all that the history and examination is 80% of your diagnosis or how you are plan to manage the case. That is why. And another very important thing also I want to tell you is what you are trying to take the history is not like any MD general medicine or surgery student is going to take, because what you are actually doing is a pre-anesthetic evaluation. It is not trying to find some diagnosis of the case, because already you would be knowing majority of the times already you are there every day, you are managing the cases. So when you are going for pre-anesthetic evaluation, you already know what comorbid conditions the patient has. So once you already know about the comorbid conditions, you have to know what is the severity of the comorbid condition the patient has and how to optimize. Suppose if it is very severe, how to bring it to an optimized status, how to prepare him, and what other extra investigations you would like to ask for these patients, and what drugs the patient is on, whether to continue these drugs or not on the day of surgery. And you plan your anesthetic technique, and also you plan the management intraoperatively and you plan postoperatively. So your pre-anesthetic evaluation presenting also, it is only the pre-anesthetic evaluation you are presenting, history examination. You will not be given any investigation. So you will have to talk about investigations in the examinations. So these things very important. And the history, it is very important to ask only majority of the questions you will be asking are leading questions. Unlike, for example, now you have passed your MBBS. In the MBBS in medicine case, when you are taking, you are told that not to ask any leading question, isn't it? So you'll be just listening to what the patient will be telling you, and then you are noting down and you are trying to present it. But here everything is a leading question. So why leading question is because you will be deciding based on these leading questions. So how you are going to plan or optimize the patient, and you are assessing the severity of the patient. So that is one thing which you have to know about. So the other things, the for preparation of the practical exam, it is better you start preparing on the previous evening itself. Not that for practical exam means how you have to go there the next day, those things I'm talking about. So you'll have to keep ready everything what you want to take for the next day. So your lucky clothes, I always tell about lucky clothes, because many of you have that habit of wearing the same cloth, which probably would bring you some luck. So for theory also would be wearing, but those clothes should be very clean, neat, iron. It is always how you present yourself to the examiner makes a lot of difference. So that is one thing which you have to make a note of, and that's why on the previous evening only you have to keep your clothes ready. Your apron also should be cleanly washed and then ironed. So it should be looking nice. Then you also stick your whatever the number plate, your register number, because that is another very important thing, because there should not be any confusion for the examiner to allot you marks, because based on your number only, he's going to register number only, he's going to allot the marks. So there should not be any confusion. So that also you make it very clear. And the other things, what to take for the next day. So naturally, you have to take your stethoscope. That is very, very important. You don't ask a stethoscope from the experts there. So you take your, whatever the stethoscope you have. You have also take one, 6 inches rigid scale, because many times, especially for distances, airway distances, you will have to measure like thyrometal distance, interincisor gap. For these, from one point to another point, you will have to measure. So if you are using measuring tape, it will be very difficult. So a 6-inch rigid scale, it costs maybe about 5 rupees. So you can buy today only and then keep it in your pocket of your apron while going to the practicals the next day. The other things are the measuring tape are very, very important. And a pulse oximeter, if you have a finger probe pulse oximeter, because we call the saturation, pulse saturation as the 5th vital sign nowadays. So definitely, if you want, you will be given in the practical exam by the expert, who are being allotted. The experts will definitely give you, but it is always better. If you have one, it is better to carry that also. And I always suggest you people to carry a candle and a matchbox. Why candle and a matchbox? Any idea, Kaushik?
Snyder massive blowing test. For
Pardon?
bedside, sir, for bedside lung function test, we'll do Snyder massive blowing test.
Yeah, very nice, very nice, very good. So Snyder's match blowing test is one of the tests that you may have to do it, and it is always better to carry. And so these few things, of course, your writing material, you will have to carry that. And other thing is you just go to the exam hall at least half an hour before. And you can definitely meet many of your staff members would be there to wish you one. The second thing is the staff members will give you important tips at that particular moment. And also you will be meeting some of the experts who are going to conduct the exam on that day, not the examiners, the experts who are allotted. At least 2 experts will be there, some assistant professors or senior assistants will be there. They'll give you valuable tips for that day's cases. So that is another very important thing. So better to be there so that you relax. And what is very important thing is when you go in front of the examiner, you should relax. So that is the most important aspect of facing a practical exam. So if you relax there, answers automatically will come to your head because you will be knowing. But once you sit in front of the examiner, so many times your brain becomes blank. So that is the reason. So you just relax in front and think that you are sitting in your house and then answering. So that way, probably your anxiety levels will always come down. So these are some of the very important tips. And again, when you go inside the exam hall, where the examiners are sitting and you are supposed to sit there and then start your examination. So just go and stand there, wish the examiner, and don't try to just pull the chair and then sit even before the examiner tells you to sit. So you just go there, wish the examiner, stand there, let the examiner ask you to sit. You sit there, take your own time, and then you start presenting. And when you are asked about the questions also, you don't answer in, long answers should not be there. Only the answer to the point. And your answer should be very short and brief. Because, 30 minutes will be the time allotted for your long case. In 30 minutes, you should be able to answer many questions. Because if you are taking a lot of time in answering one question, long answers, so the examiners will not be able to even reach the anesthetic management. So that is another thing which is very, very important. And once the examiner asks a question, wait for the examiner to complete his question. So don't try to answer before he completes his question, because you may think that, okay, this is the question, let me answer. No, don't be in a hurry. And wait for the examiner to complete his question and wait for a few seconds before you start your answer. You just can think few seconds, not minutes. That's what yesterday I was telling my students also. Don't take minutes because the examiner think you don't know and he may ask one more question. So just take about few seconds, think what is the question and what to answer. And that few seconds is majority of the times will be enough for you to answer. And, these are some of the important tips. If you don't know, you just tell you don't know. Because, let the examiner ask you a next question. Because otherwise, examiner will be sitting like that. You will also be sitting like that. And valuable time will be just passing across. So just tell no, but don't tell no for all questions. Okay. So whatever you don't know, one question or 2 questions you may not be knowing, that you say, I don't know. Okay. So these are some of the important tips for you to, face the practical exam. So with these tips, so let us start our today's, case presentation. The case presentation for today is, I think, mitral stenosis of rheumatic origin, but they're not posted for any kind of surgery. We will create all case scenarios and then we will discuss about, for example, this patient is posted for a lap cholecystectomy, how we are going to manage, or hernia repair, how we are going to manage, a pregnancy, labor analgesia, how we are going to provide, a cesarean section, how we are going to provide. As the short for patient is posted for an MTP. So how we are going to manage medical termination of pregnancy. So these are some of the case scenarios we can always create and then ask you. Okay. So let us start with today's discussion. Okay, Kaushik or Shruti, you can start presenting the case.
Okay, sir.
I think you can share your PPT, yeah.
Yes, sir.
I'll start, sir.
Yeah, please.
Mrs. Shanti, a 36-year-old housewife, resident of Kadlur, low socioeconomic status, came with chief complaints of difficulty in breathing for the past 3 months. History of presenting illness. Patient was apparently normal before 3 months, after which she started feeling breathless while climbing 2 flights of stairs. That's NYHA class 2, which has progressed over the last 2 weeks such that she feels breathless while doing her regular household work. NYHA class 3. Breathlessness was gradual in onset, progressive in nature, aggravated upon doing housework, and relieved by taking rest. History suggestive of paroxysmal nocturnal dyspnea present. No history suggestive of orthopnea. Breathlessness was associated with palpitation for the past 1 month. History of EC fatigability present. No history of cough with expectoration. No history suggestive of syncope. No history of leg swelling. No history of right abdominal pain. No history of reduced urine output. No history of recurrent fever with chills and rigor. No history of recurrent respiratory tract infections. No history of transient loss of consciousness. No history suggestive of hemoptysis. No history of hoarseness of voice. No history of dysphagia, and no history of chest pain. Past history. Patient had a history of recurrent fever episodes associated with joint pain at the age of 16 years. Not a known case of type 2 diabetes mellitus, systemic hypertension, bronchial asthma, epilepsy, or thyroid disorders. No history of previous surgeries. No history of previous hospital admissions due to breathlessness. Family history, there was no significant family history, and personal history, normal bladder and bowel habits. Menstrual and obstetric history, she attained menarche at the age of 14 years with regular cycles, 3/28 days. No history of dysmenorrhea or menorrhagia. She is married. She has 1 child born of normal vaginal delivery. During childbirth, she developed breathing difficulty for which she was admitted in the high dependency unit and was treated with oxygen and medications. Treatment history. She's been receiving IM injections every 3 weeks since the age of 16 years. She takes a tablet for 5 days and does not take it for 2 days, and subsequently continues the same for the past 3 months. She takes a tablet to help her pass more urine for the past 3 months. Summarizing the history, a 36-year-old female with a history of breathlessness for 3 months and palpitations for 1 month, with worsening of NYHA for the past 2 weeks, with past history suggestive of rheumatic fever, probably a valvular heart disease of rheumatic origin, and not in cardiac failure.
Okay, so usually majority of the times what as examiners we do at the end of your history, once you say that, okay, this you're going to summarize and you have come to a provisional diagnosis at the end of history, isn't it? So once you say, then we will be asking you, what are all the positive findings in your history to say or to come to this particular diagnosis? So for that, you'll have to start with the whatever the introductory thing as far as the patient is concerned, because you had introduced the patient, isn't it? Patient's name, age, gender, address, and all those things. So from there only we will have to start. So if we just see the introduction, you said that, Mrs. Shanti, 36-year-old housewife and resident of Kudalur, of low socioeconomic status. So with this just introduction of the patient, are there any positive findings for you to say that yes, this patient may be a known case or maybe a case of rheumatic heart disease? Can you just tell what are the positive things in this introduction itself? Because from the introduction everything becomes very important. And another very important thing I just want to tell you, when you are introducing the patient, it is better you take a detailed address of the patient, just not resident of Kudalur. Sometimes even I'll ask my postgraduates to take the mobile number of the patient and also write down the mobile number and then tell the examiner this is the mobile number. So why do you want this kind of a detailed address and mobile number to be taken when you are presenting in the exam? What is the advantage of taking a mobile number also and a detailed address?
So follow-up, sir.
Yeah,
We need
very
to follow up the patient.
Very good. Because, once you tell this is the mobile number, so many of the examiners, they laugh and then they'll immediately ask, now, why did you take the mobile number? Because, it is very important to follow up these patients, because many times you must have seen many of these trials that are done, 30-day mortality, 1-year mortality, morbidities, 1-year morbidities, and all those things. So you also should always follow up your patients. So that is the reason it is very important that you always present the detailed address of the patient and also the mobile number of the patient. So that is one thing which you have not written here. The other important thing about this, she is a female patient, 30-year-old.
Yes.
Any important clue for the positive clues for your final diagnosis as far as the history is concerned?
So mostly the rheumatic arthritis is commonly seen in 30 to 40 years of age group women, especially females are most commonly affected, sir.
Yes,
And,
very so younger age group, isn't it? So younger age group in Asian countries, because you'll have to think about two things, because the mitral stenosis can occur in Asian countries and all, that is the developing countries, and also in West developed countries also. And usually the age of onset in developed countries is usually very late, because it is majority of the times it is because of degenerative changes that take place in the valve or calcification that take place in the valve. So usually they present at maybe 5th or 6th decade for mitral stenosis, because rheumatic history or rheumatic disease, rheumatic heart disease is almost not there in developed countries. It is still there in Asian countries. So in Asian countries, rheumatic fever is quite common, and mitral stenosis, one of the most common causes of mitral stenosis in the Asian countries is rheumatic fever. So, and usually, what is the time or age at which these patients would have developed or would have contacted the infection for rheumatic fever? What is the causative agent for rheumatic fever?
Beta hemolytic streptococci.
Yeah, beta hemolytic streptococcus, isn't it? So they would have contacted early in their age group. And once they have contacted this early in this age group, so what is the time duration for them to develop symptoms of cardiac disease?
20 years.
Yeah, in Asian countries, it is very early. It can be as early as 10 to 15 years. Many times, even just 10 years. And by the time they have contacted, usually about between 5 to 10 years of their age, they would have contacted the infection. And by 20 years already, they are presenting with symptoms. So that is why 30 years, sure, definitely you can say it's one of the plus points for finally coming to the diagnosis of rheumatic heart disease. Another thing is female patients. Kaushik was telling that female patients are more prone for rheumatic heart disease. What is the incidence, male-female or female-male ratio of rheumatic fever or rheumatic heart disease as such? So the ratio is 3:1. 3 times females are more prone for development of rheumatic fever and rheumatic heart disease especially. So that is another thing. And one more thing you have written here is poor socioeconomic status, low socioeconomic status. Does it have anything to do with finally to come to a conclusion, positive findings in your history?
People of the low socioeconomic status are more prone for rheumatic fever, sir.
No, why do you think like that? Why they are more prone? No, there has to be some reason, isn't it? Is it nutritional deficiencies they have? It is actually, the infection, spreading of the infection, because many of the children and the family members will be, sleeping at one roof, a single room probably, and very close contact will be there. And because of the close contact, spread of infection is very, very common. So plus probably the nutritional deficiencies they also may carry. So because of these things, they are highly prone to develop these patients with low socioeconomic status. So these things are very important when you are presenting. So you can tell at the end what are the positive findings. So you can start with the patient's gender and other things, how patient is prone for rheumatic heart disease. So other thing is, now you have presented with chief complaints, difficulty in breathing for the past 3 months. That is another thing. Many times what happens is, when in the exam, there may be chance that the patient has got admitted for some surgery as well. And the comorbid condition can be your rheumatic heart disease. That is always there. So then you'll have to start presenting first as why the patient has been admitted for a particular non-cardiac surgery, or the patient would have been admitted, isn't it? So that you have to tell about, and then briefly you have to discuss about that, and then you have to go for comorbid conditions. Because for us, it is the comorbid conditions are more important. So here in this particular case, your case, the patient has not been admitted for any kind of surgery, but patient has been admitted for aggravated the problem of the heart disease, isn't it?
Yes.
That must be the reason why the patient.
Yes, sir.
Yes, sir.
Now we have written that the patient has breathlessness for the past 3 months. So again, this you may have to say, is it difficulty in breathing for the past 3 months or increased difficulty in breathing for the past 3 months? So that is another very important thing, because they just cannot start having symptoms just in 3 months. Symptoms would be there because later you have also presented there the ICU also, and was given some treatment like oxygen and other things were given. So that means probably the symptoms would be there. So when you are presenting, probably you can say that there is increased difficulty in breathing. That you can always mention instead of just say difficulty in breathing for the past 3 months. Then during your history of presenting illness, again, you have to describe more regarding the dyspnea itself or difficulty in breathing. Now, one question for you is why these patients with rheumatic heart disease, especially mitral valvular heart disease, they develop breathlessness. What is the cause for breathlessness in these patients?
Because there is a mechanical obstruction because of a stenosis mitral valve, so in mitral stenosis, because of which the blood flow from the left atrium to the left ventricle will be reduced. So more blood starts getting pooled up in the left atrium. That will cause an increase in left atrial pressure, thereby causing an back pressure to the pulmonary venous system, and causing pulmonary interstitial edema and pulmonary edema. So that will cause increased work of breathing and dyspnea.
Very good, very good. So that is one of the things, and also there will be lung changes also will take place gradually because of this, and that also produces a decrease in the compliance of the lung. We'll discuss that later when we discuss about the pathophysiology of the mitral valvular heart disease. Of course, as you said, it is always one of the symptoms of left-sided failure. This initially they'll have. Of course, later, once they develop pulmonary hypertension, they do develop the right heart failure also. So initially, all the symptoms are because of left heart failure only. So the dyspnea you'll have to describe, as you already discussed it, as that the patient had initially class 2 NYHA and then class 3 and all those things. So climbing 2 flights of stairs, what you have discussed, does it come in class 2 or class 1 dyspnea? Is it a normal activity or more than normal activity for her? Where does she stay? Does she stay in an apartment or somewhere where she has to climb 2 flights or 3 flights? If she was climbing every day 2 flights of stairs, then it becomes an ordinary activity. Of course, once she develops, now it can be, you can always say that it is class 2. Anyway, how can you just describe how we are classifying this NYHA classification for heart failure, different classes, class 1, 2, 3, 4. Kaushik can answer. What is class 1, what is class 2, what is class 3, and what is class 4?
Yes, sir. In NYHA, we'll see the symptoms of cardiac, sir. We'll see angina, palpitation.
No. What is class 1 NYHA? NYHA is always for dyspnea or breathlessness due to exertion.
Yes,
That
sir.
is NYHA classification only I'm asking you, because you have written NYHA class 2, class 3 patient
Yes, sir.
has developed. So how do you classify this? What is NYHA class 1? Because this is one of the common questions we'll be asking you in the exam. A simple question.
Sir, in NHA class 1, patient doesn't have any symptoms on normal daily regular activities, sir.
Okay. Ordinary activity
there is-
is symptomatic.
And there is no limitation of activities.
Okay, very good. Very good. Class 2 is?
Class 2 is the patient having symptoms while doing the normal regular activities with mild limitation of symptoms. Mild
Okay.
limitation of
Ordinary
activities.
activity, patient will develop symptoms. Okay. Class
Yes,
3?
sir. In class 3, the patient developing symptoms less than the normal regular activities, sir.
Minimal
And
activity.
yes, sir.
Minimal activities, isn't it? And class 4 is?
Patient having symptoms doing at rest itself, patient developing symptoms, sir.
Even at rest. Even at rest. Now, what you have written is regular household work she is not able to do. That is what you have written as class 3, isn't it? So regular
Yes.
household work is ordinary activity or
Less than
Ordinary.
ordinary physical activity.
isn't it? So if she is not able to do her regular ordinary activity, it will be class 2, isn't it? So why these are very important is the importance of classification. So what is the importance of classification? Why should you classify dyspnea?
Sir, you want to see the severity of the disease, sir?
Okay, one is for knowing the severity of the disease. Very good.
And next for assessing the patient for a surgical plan or what is the medical management.
Okay, very good. So why do you just said that you may think of surgical management for this patient? So, or any interventions for that matter. It
Yes,
can
sir.
be balloon mitral commissurotomy is also one of the interventions. It's a temporary intervention, of course. So why do you think that, or what are the indications for interventions other than the medical therapy?
Indications is when the patient has symptoms of the patient is not subsiding with medical management. So.
Okay. Is it just that, you said that why I asked you this question is severity of the dyspnea itself. So once the patient has NYHA class 3 or class 4, definitely patient may require some
Surgical interventions.
is one of the indications. Second indications, of course, you may have to look for the pulmonary artery pressures. If the pulmonary artery pressures are more than 50 millimeters of mercury, especially systolic pressure, I'm not talking about the mean pulmonary arterial pressures. That is another indication for intervention. The third indication for intervention is if the patient also has developed atrial fibrillations. So these three are actually the indications for some intervention, either surgical intervention or percutaneous intervention, other than continuing only medical line of management. Because if the patient has been posted for an elective procedure, definitely when you go through with the history and you find these things for any NYHA class 3 or class 4 patient having atrial fibrillation, that you can definitely know by examination of the patient, by even the pulse many times and ECG. And through echocardiography, you know what is the pulmonary artery systolic pressure. If they are high, definitely you can discuss with the cardiologist, and then you can plan for an intervention before actually taking up the patient for elective procedure, because you'll have a lot of time for elective procedure, isn't it? So just like that, elective procedure, when I tell, how do you classify these timings for these surgeries as such? When do you say it's an urgent emergency surgery, urgent surgery, time-sensitive surgery, elective surgery? What is emergency surgery? Now, why I ask you this is, you as an anesthesiologist, you are supposed to know, because then you know how much time you have to optimize the patient's condition. And another very important thing is, in the exam, we can ask any question. So what happens is you will have, you will be thinking, okay, I'm to present this mitral stenosis. So the questions will be only towards this. suddenly, the questions may shift to other systems as well. So that you should always remember, and what answer you will give from there only, everything can deviate. So that's why when you are answering also, you have to be careful in answering the questions. You can actually take the examiner towards what you exactly know. All those questions towards what the important things you will be knowing. So the discussion will be going towards that. Now, just answer this because, there are many students are listening to this. So everyone will be benefited. So what do you mean by emergency surgery?
Sir, emergency surgery is a surgery required immediately or within an hours. And
what kind of surgery you call it as an emergency surgery?
Sir, aortic aneurysm.
Say life-saving or limb-saving surgeries.
Limb-saving surgeries, sir.
Life-saving or limb-saving surgeries.
Okay, sir.
Even a cesarean section can be an emergency surgery. If it is an emergency, it's not made an emergency. Real emergency, cesarean section can be an emergency, or any other thing, life-threatening condition for which you have to take up. So you will have maximum, other than cesarean section, you will have maximum about 2 hours to optimize the patient. In all life-saving, limb-saving surgeries, the amount of time you will have about 2 hours. So that is the time you may require to optimize the patient. For example, now this particular patient may be an anticoagulant therapy and may be posted for some real emergency surgery. So then optimize her coagulation status, because you cannot just take it. So that is why you may have only about 2 hours for managing such cases to optimize and then take up for surgery. So, okay, what is urgent surgeries?
Surgery to be done within 24 to 48 hours, sir.
Very good. 24 to, can you give an example like?
Sir, acute appendicitis.
24 to.
Acute appendicitis. Acute appendicitis.
Appendicitis, okay. Mainly, the fractures you can always say. Fractures, especially the hip fractures in old people, geriatric patients. Because you cannot postpone for a long period. These geriatric patients, hip fractures, you have to take them up within about 48 hours. Ideal would be 24 hours or maximum about 48 hours. So such urgent surgeries, at least you will have over 2 days to optimize their status and then to take up. So that is why they are called as urgent surgeries. Time-sensitive surgeries.
Sir, it is not an emergency, sir, but it should be performed within a specific time frame.
What specific time frame you can always say? Time-sensitive.
Sir,
usually about 4 to 6 weeks. Time-sensitive, especially all these, oncosurgeries, cancer-related surgeries. You cannot postpone indefinitely, isn't it? So you have to take them up as early as possible, but not urgently. And definitely not an emergency, not urgently also. So you have, that is why these oncosurgeries are definitely the time-sensitive surgeries. Because if you keep on postponing, spread will be very common. So then, you may not be able to do even surgeries also. So that is why they are always called as time-sensitive surgeries. So especially in a patient with who has had a stent placed and the patient is on dual antiplatelet therapy, just patient has been placed on, PCI has been done about 1 month back or 2 months back. A patient has had a myocardial infarction about a month back. Now, you cannot postpone these patients for indefinitely, isn't it? If they are posted for time-sensitive surgeries, and they'll be on antiplatelet drugs, whether to continue them, whether to stop them, which one to stop, all those things you will have to think about the time-sensitive. And of course, elective surgeries, you can even postpone for 365 days, absolutely no problem. You'll have a lot of time to optimize these patients. So that is why you should always know about these different kind of surgeries as such. So that is why that is one thing. And second thing is, you said that you have written in this, you have to be extremely careful with how you present. You have written that the patient's breathlessness is gradual in onset. So can it be in 3 months, everything gradual in onset in just 3 months, especially of mitral stenotic breathlessness? Is it so fast. 3 months is not very long, isn't it?
Yes, sir.
One thing you should realize, mitral stenosis problems like of left heart failure problems, isn't it? So it will cannot be just 3 months history. So though the complaints might have Shruti, Shruti, you're there? Shruti and Kaushik? I'm not able to hear you. Electricity has gone, is it?
Yes, sir. Power cut, sir.
Okay, okay.
Yes.
Okay. So that is what, though you may say that the exaggerated symptoms for the past 3 months, but you have to go into details about how long the patient, how it has progressed, isn't it? So when do you think that, sudden increase in the breathlessness in these patients with mitral stenosis, when they can have sudden increase, sudden onset of breathlessness, though it was very gradual to begin with, what conditions make them to have sudden increase in the symptoms of breathlessness?
They have an associated atrial fibrillation, sir.
Yes, very good. One is if they suddenly develop atrial fibrillation. Till now, they have not had their atrial fibrillation, and anytime they can develop atrial fibrillation. That is one reason. Okay, what are the other reasons why sudden increase in the... So they may be having NYHA class 1. Suddenly, they may go for NYHA class 3 or class 4. So one is atrial fibrillation, uncontrolled ventricular response. Okay, what are the other things? More simple than that. Yeah.
Right heart failure.
No. That will take a long time. Right heart failure. That is a last part of mitral stenosis. If they develop fever, what happens to the heart rate? Heart rate increases. We'll come to pathophysiology. Any increase in heart rate, sudden increase in dyspnea can occur, isn't it? So the third thing is, if a patient has developed pregnancy, has become pregnant, isn't it? So this patient, as you said in the history itself, in abstract history, patient was having more breathlessness and also admitted to the hospital, admitted to ICU. Pregnancy itself, because the physiological changes in pregnancy will increase the heart rate, increase the cardiac output, and that too, as soon as the mother delivers, another say 500 to 800 ml of blood gets auto transfusion occurs, and this amount of sudden extra preload also the patient will not take up, will not tolerate. And the increase in heart rate itself, as the pregnancy progresses, they may become more symptomatic. So pregnancy is another thing. Okay, what are the other things? Suppose if the patient develops thyrotoxicosis, because Graves' thyrotoxicosis is again in young females. It is an autoimmune disorder, and rheumatic heart disease is also an autoimmune problem. It is not directly the bacteria have gone and infected the valve. It is an autoimmune antigen-antibody reaction. So Graves' disease also can occur in these patients. So if they have developed thyrotoxicosis, again, there can be sudden onset of increased severity of the symptoms. And the other thing is anemia, because females are known to develop anemia. And especially you are telling out low socioeconomic status. And also, every month, the menstrual cycles, they bleed. And that also will add on to the anemia problem. So again, anemia, what is the compensatory mechanism in anemia?
Tachycardia.
How the body... Tachycardia, one, it has to increase the amount of blood flow to all the tissues, because the oxygen carrying capacity of the blood has decreased, because oxygen content has decreased, isn't it? So in order to make good the oxygenation of the tissues, so the flow has to increase. That means the cardiac output has to increase. So how cardiac output can increase? One is increase in heart rate, another is increase in stroke volume, isn't it? So contractility. The stroke volume has to increase. That means the more blood has to flow across the mitral valve. That also can induce, isn't it? So these two are the compensating. Any other compensating mechanism just like that for anemia, other than increase in cardiac output? Anything as far as oxyhemoglobin dissociation curve?
Sir,
What happens to oxyhemoglobin dissociation curve in anemia?
sir, curve will shift to right outside, sir. Right
Yeah,
outside
yes,
of oxygen dissociation curve, sir.
yeah, because once it is shifted to the right, the hemoglobin can release oxygen easily to the tissues. The affinity of the hemoglobin to oxygen will come down, rightward shift. That is another, compensatory mechanism. So one more compensatory mechanism, as such, because of the anemia itself, what happens to the viscosity of the blood?
Increase blood viscosity.
Increases or decreases? Solid content has come down, isn't it? Once the hemoglobin is
Dilution.
not dilutional, as such, whenever anemia is there, so viscosity will come down. And once the viscosity comes down, based on Hagen-Poiseuille law, you know what is Hagen-Poiseuille law, isn't it? Rho is inversely proportional to viscosity. And that's how, easily the blood can flow. More amount of blood can flow for that particular time to the tissues, and the tissues will get more oxygen. So these are all the things which can take place. So anemia, increase in heart rate, try to, increase the amount of blood flow across the mitral valve will produce a sudden increase in the acute increase in the severity of the symptoms. This is commonly we will be asking you. So one is, as I said, fever. Second thing is the patient becoming pregnant. Then patient having thyrotoxicosis, sudden development of atrial fibrillation, and anemia. So now another thing you said, that atrial fibrillation. So can it be continuous atrial fibrillation or a paroxysmal atrial fibrillation? Initially, because that particular thing, I think you have not told in your history about the palpitations. Have you mentioned about the palpitations in the history?
Oh, yes.
Yes, sir.
Yes, sir.
When she developed palpitation? Yeah, breathlessness associated with palpitation for the past 1 month, isn't it?
Yes.
So history of whenever, what do you mean by palpitation? What is the definition of palpitation?
It's the awareness of one's own heartbeat, sir.
Unpleasant.
Abnormal awareness or just awareness?
Abnormal awareness of the one's own heartbeat.
Abnormal awareness of one's own heartbeat. Like, abnormal awareness of one's own breathing is called as, breathlessness or shortness of breath or dyspnea, and abnormal awareness of one's own heartbeat is called as palpitation. Because these simple definitions will be asking you in the exam. So palpitation means what is the cause for this palpitation? Palpitation is a symptom. It is a symptom of what?
Atrial fibrillation.
It need not be atrial fibrillation. Any tachyarrhythmias. Any tachyarrhythmias can produce palpitation. Even bradyarrhythmias can produce palpitations. But majority of the times it is the tachyarrhythmias. So it can be supraventricular tachyarrhythmias, atrial tachycardia, paroxysmal atrial tachycardia. It can be atrial fibrillation, or it can be even VT. All these can produce palpitation. So the history of palpitation is very, very important. And any sudden, this history of palpitation and patient going in for, severe symptoms of dyspnea. So you can say that that is the time when the patient might have gone in for atrial fibrillation. And atrial fibrillation is very common problem in these patients with MS, isn't it? So why do you think that these patients can develop atrial fibrillation? The patients with mitral stenosis, what may be the cause?
It's because of the left atrial enlargement, sir.
Yes,
so
very
because
good.
of that, there will be an stretch of the atrial conduction fibers.
Yes.
So
You
it
can
links
just say it is because of the left atrial enlargement. Definitely, these patients are highly prone for reentrant phenomenon. So because there are two methods by which dysrhythmias can occur. One is automaticity, another is re-entry phenomenon, isn't it? Majority of the time, these atrial fibrillations are because of re-entry phenomenon. So the patient can develop. Atrial fibrillation is one of the most common dysrhythmias in patients with chronic mitral stenosis. And almost it is said that 80% of the patients will develop atrial fibrillation. So that is very, very important thing. So that is another thing which you have come across. One more thing you have said about the dyspnea, very commonly asked question for and very common or many of the examiners are very fond of asking is PND, history of PND. So you have written that there is no history suggestive of paroxysmal nocturnal dyspnea. Shruti, can you just tell what is this PND, the mechanism of PND?
Yes. Paroxysmal nocturnal dyspnea usually occurs at the time of sleep. Once a patient has gone to sleep for the period of 2 to 5 hours, it awakens the patient from the sleep, and it takes about 10 to 30 minutes for the symptom to relieve after attaining an upright position.
Okay, so that is usually how paroxysmal nocturnal dyspnea occurs. Very good. So why this 2 hours or 3 hours and nocturnal? Always it is paroxysmal. So it is not there throughout the day. It is a paroxysmal one and it's a nocturnal one, and dyspnea, of course, breathlessness. So in that nomenclature only it is there. So why it occurs after about 2 hours? Why not immediately the patient goes to sleep?
There are two reasons. So one is once the patient goes to sleep, there'll be a reduction in the PaO2 levels, and other one is because the sympathetic supply to the left ventricle will be reduced.
Is it that thing? What happens to the venous return?
Sir, and one more thing is the patient is in a lying position for a long duration.
Yes.
So gradually the increase venous return and increase the preload, sir. So the patient is feeling dyspnea, sir.
Increased preload of what? Which particular chamber? Increased preload?
Sir, right ventricle, sir. Right atrium followed by right ventricle, sir.
Right ventricle afterwards, what? It is the right atrium here, isn't it?
Yes, sir.
So increased amount of blood in the right atrium, but right atrium, after the right atrium, there is an obstruction. Sorry, left atrium. After the left atrium, there is an obstruction. So once there is an obstruction for the flow of blood from the left atrium to the left ventricle, now the backflow. Because more blood has entered into the pulmonary circulation, there is a pulmonary congestion. And once there is a pulmonary congestion is there, once the hydrostatic pressure, capillary hydrostatic pressure exceeds the oncotic pressure, the fluid will start entering into the interstitium of the lung and also into the alveoli of the lung. So once it starts pouring there, naturally the patient's compliance of the lung will decrease and also hypoxia occurs. Because now, in alveoli now fluid has accumulated. Once the fluid has accumulated, exchange of gases, especially for oxygen, it's decreased. So patient will develop hypoxia, and plus the work of breathing will increase. So because of this, the patient will immediately, plus of course, as you said, that hypoxia that occurs will also stimulate the respiratory center to make him to breathe more. That's why he becomes tachypneic, and also breathless because the compliance of the lung has decreased. So all these things will produce increased breathlessness for him. So he wakes up. He wakes up because of the breathlessness. Once he wakes up because of the breathlessness, what he does now?
He goes to the open window.
Going to the open window will help, or erect posture will help?
Erect posture.
Erect posture, sir.
Yeah. Because the mechanism of this thing was increased venous return, increased pulmonary congestion, isn't it? So once he wakes up, he gets up, he attains an erect posture. So the amount of blood traveling back into his right atrium, right ventricle, and to the pulmonary system is suddenly come down. So pulmonary congestion comes down once the pulmonary capillary hydrostatic pressure has come down. So naturally, the amount of fluid going from the pulmonary capillaries into the interstitium of the lung decreases. In the meantime, the pulmonary lymphatics will overwork and then remove whatever the fluid that has been accumulated there. So it will take about 10 to 15 minutes for the patient to completely get relieved of this paroxysmal nocturnal dyspnea. So one question to Kaushik. So suppose the patient also is a bronchial asthma patient, let us say. Okay, he can also have a acute attack of bronchial asthma in the night. If he develops an acute attack of bronchial asthma in the night, that is called as respiratory asthma, that is a bronchial asthma, and PND is a cardiac asthma. How do you differentiate between these two? Bronchial asthma and PND, cardiac asthma. Because the management is different for these two. Management is not.
Sorry, in bronchial asthma, there is a cough which is followed by dyspnea, sir. But
Very
in,
good.
yes, sir, but in a cardiac PND, there is a dyspnea which is followed by cough, sir. May or may not be followed by
Okay.
cough.
Very good. One very important thing. Yes. What
And in
next?
bronchial asthma, there is we can hear the audible wheeze, sir.
No, here also you can. Definitely, there can be reactive narrowing of the bronchi and bronchioles also can occur even in PND. But more important thing is how bronchial asthma gets relieved. Does it get relieved once the patient have an erect posture, goes to the windows, try to take deep breaths? It
No,
will
sir.
not be relieved, isn't it? It will be relieved only by bronchodilators. Whereas cardiac asthma will be relieved by, just attaining the erect posture. Within few minutes, the patient will get relieved. And another very important thing is the patient will have previous history of bronchial asthma attacks. Whereas the cardiac asthma patient will have history of cardiac disease. So that's how, this is again a common question we'll be asking you to differentiate between PND and bronchial asthma. So a lot of questions will be asked for PND. And Shruti, once the patient has, so let us say the patient was in your history, she was telling that she was having a NYHA classification of 1. And now she also gives history of PND. Where do you classify as far as NYHA classification is concerned for her?
NYHA class 3 will be having a symptom of PND, sir.
It will be class 4. What is class 4?
Class 4 is
At
breathlessness at rest. Yes, sir.
She is at rest only. She has developed breathlessness at rest, isn't it? And any of this history of PND, you always classify as class 4. And another very important thing is, suppose the patient gives you a history of PND sometime back, maybe about 2 years back. Another patient is there who gives history of PND maybe about 2-3 days before also, almost every night she is having. So how do you differentiate as far as these two patients are concerned, as far as your anesthetic management is concerned?
The one who had PND in the last 2-3 days will be having a more severe disease, sir.
Yeah, more severe disease and also requires more time for optimization. And even may require some procedures like balloon valvuloplasty or even the valve replacement, isn't it? Or some patient who has had 2-3 years back, now for the past 2-3 years back, since 2-3 years, fine, and managed by medical treatment, so may not require so much of optimization. Definitely, the morbidity or even the major adverse cardiac events intraoperatively or perioperatively may be much less. That's how you will decide, isn't it? So these two, history of dyspnea, the grading of dyspnea, and then paroxysmal nocturnal dyspnea, and history of atrial fibrillation, are very, very important for you to decide whether the patient has a mild disease or a severe disease. So who requires more optimization, who requires less optimization. And another very important thing regarding atrial fibrillation, I was telling about, it can be paroxysmal or it can be persistent. When do you say it is paroxysmal and when do you say it is persistent?
When the atrial fibrillation relieves within a period of 7 days, it's called paroxysmal, either with treatment or without treatment.
Yes, very good.
Persistent will be
more than 7 days.
More than 7 days.
Yeah, that you call it as persistent atrial fibrillation. So this lady has developed about a month back, as you said, palpitations. Probably that is the time she must have developed atrial fibrillation with your history, what I'm trying to know about, isn't it? So that means it is still there, isn't it? It is more than 7 days. So she might have developed a persistent atrial fibrillation. So one more thing as far as the atrial fibrillation, because let us just finish this atrial fibrillation because patient has atrial fibrillation. So one more important thing about atrial fibrillation, whenever a patient has atrial fibrillation, as an anesthesiologist, what else you should think the patient may be on?
Patient may be on anticoagulant therapy, sir.
Anticoagulant therapy, isn't it? So that is very common. Why a patient who develops atrial fibrillation may be on anticoagulant therapy?
Because of left atrial, to prevent the left atrial thrombus formation, sir.
So they are prone for, because there is no left atrial contractility, isn't it? It is fibrillating. There is no proper contractility. So stasis of blood can occur even without mitral stenosis. Even, for example, if the atrial fibrillation may be for some other problems also, the patient can develop left atrial thrombus. So in these patient can be on anticoagulants. One. Second thing is what you have to rule out in these patients by any particular investigations before accepting the patient for surgery.
We have to do iners.
Pardon?
We have to do an echo.
Echo, sir. Echo.
Yeah, echo and then rule out.
Sir,
left atrial thrombus.
Yeah, left atrial thrombus. So that is very important. Any patient with a left atrial thrombus don't accept for any kind of the elective procedures. And one more thing, as far as the atrial fibrillation, you have to look for the rate, isn't it? So whether it is a controlled atrial fibrillation or uncontrolled ventricular response to atrial stimuli. Again, Shruti, why should you know whether it is a controlled? When do you say it's a controlled atrial fibrillation? When do you say it is uncontrolled?
For a patient without heart failure, we can accept a rate of up to 110 beats per minute. Sir. For a
Usually
patient
less than 100. You can say controlled is usually 60 to 80 is ideal. Controlled, very well controlled. At least it should be less than 100. But if it is more than 100, definitely it is not a controlled atrial fibrillation. So why again, Kaushik, should you know whether it is a controlled atrial fibrillation or an uncontrolled atrial fibrillation? Why? What is the importance for you as an anesthesiologist?
Because uncontrolled heart rate is more than 100, sir. Tachycardia is detrimental for left ventricle filling time.
That is okay. No, there are certain things we call as active cardiac conditions. Can you just name active cardiac conditions? Where these patients, if they are taken up for surgery with active cardiac conditions, the major adverse cardiac events are very high. So you don't accept them if they have any active cardiac conditions for elective procedures. Only they are to be accepted for emergency surgeries, life-threatening or limb-threatening emergency surgeries. Can you name some active cardiac conditions? One active cardiac condition is already we are just now discussing. Any uncontrolled atrial fibrillation is an active condition. Any other active cardiac conditions you know of?
Recent MI.
Recent MI or an acute MI? Both. Acute MI, which is 7 days, within 7 days. Recent MI within 28 days. Okay. Anything else?
Having any aortic dissection?
No, severe aortic stenosis or severe valvular stenosis. With severe mitral stenosis, severe aortic stenosis can be an active cardiac condition. Yes, then patient in cardiac failure, uncompensated cardiac failure. That is again an active cardiac condition. And malignant dysrhythmias, patient with malignant dysrhythmias, especially uncontrolled atrial fibrillation or even a monomorphic VT. All these are called as active cardiac conditions. So if these patients having any active cardiac conditions, you cannot accept them for any kind of elective procedures. You have to optimize these patients, then only you have to take them up for even unstable angina is an active cardiac condition. It need not be an acute myocardial infarction, including unstable angina. So that is why, atrial fibrillation, when you say, definitely you'll have to palpate for the pulse or you go for ECG and get the heart rate. And then if the heart rate is definitely more than 100, it is an uncontrolled atrial fibrillation and you don't accept these patients for any kind of elective procedures. Okay, so that is another thing as far as your history was concerned. And you have also written that no history of syncopal attacks. So why you have written that syncopal attacks in these patients? What may be the cause of syncopal attacks in a patient with mitral stenosis?
So due to left atrial thrombus formation and there is a reduced blood supply to the brain, sir. So patient may develop.
The thrombus formation will not produce any decrease in blood supply to the brain.
Because of the low cardiac output state, sir. mitral in a low cardiac output state. So the
No, which
syncopal
valvular heart disease, produces early syncopal attacks as far as the low cardiac output is concerned?
aortic
It is
stenosis.
aortic stenosis, not the mitral stenosis. Mitral stenosis, the cause for syncopal attacks or even TIS the patients can have is because the microemboli the brain may receive, because stasis of blood in the left atrium, microemboli thrombus may form, and these thrombus may enter into the left ventricle and then pass through the aorta and then can induce microembolization of the vessels there and can induce syncopal attacks. So that is another very important thing. And many times these patients can even present with stroke. They may not have presented with mitral stenotic symptoms. They may present with stroke. And when they have had a stroke and when you try to investigate, you may find mitral stenosis in these patients. So that's how, the cerebral symptoms are very, very important. So you should try to ask about cerebral symptoms and then try to know whether they are there or not there. Okay, that is another important thing as far as your history is concerned. Then you have written, no history of cough with expectoration. So why did you write down about cough with expectoration? Any particular reason? Okay, Shruti, you can answer. Cough with expectoration.
To rule out any recent URI or LRTI.
No, are these patients prone for repeated respiratory infections?
Yes, sir. Yes, sir.
Yeah, that is very important. Why they are prone for repeated respiratory infections?
Due to the pulmonary congestion.
Very good.
They are more
yes,
for it.
Yes. Because of the pulmonary congestion, they are more prone for repeated respiratory infections. So any recent respiratory infection, definitely you will not take up for elective procedure. So again, Kaushik, why you are bothered about upper respiratory infection? Why you don't want to take up for any elective procedures, especially if you're planning GA?
Sir, because of hyperactive airway, more prone for laryngospasm, bronchospasm. So
more important bronchospasm rather than the laryngospasm. Of course, laryngospasm also can occur. Upper respiratory infections, that itself is a short notes for you. Upper respiratory infections and anesthesia, especially children. When even you may have a short case of tonsillitis child as a short case for you. So again, these children with tonsillitis will have repeated respiratory infections when they are posted. Usually, when they have an upper respiratory infection for elective procedure, how long you wait before taking up for surgery?
4 to 6 weeks.
Pardon?
4 to 6 weeks.
Yeah, 4 to 6 weeks. Why, Shruti, 4 to 6 weeks?
Because the airway will be reactive for a period of 4 to 6 weeks. So we need to...
Why airway will be, hyperactive? What is the cause for hyperactivity of the airway?
Sir, because of the vagal nerve endings are
very
more
good.
stimulant.
Vagal nerve endings become hypersensitive. So the risk of acetylcholine will be much more for any stimulation of the upper airway. So that is why you have to wait for, ideal would be about 4 to 6, but usually about 3 weeks you may have to wait. Repeated respiratory infection is one common problem in these patients, so that you have to be aware of that. Another thing you have written about hemoptysis. So what is the cause for hemoptysis in these patients? Do they have hemoptysis?
Yes, sir.
Yes.
Patients. Okay, Shruti, you can answer.
Because of pulmonary apoplexy, sir. Because the left atrial sudden increase in the left atrial pressure will cause rupture of the bronchopulmonary veins.
Bronchial veins. Rupture of the bronchial veins, isn't it? So why rupture of the bronchial veins can occur?
Because of the sudden increase in the left atrial pressure, sir.
Is it sudden increase in the left atrial pressure? No, there is an increase in the left atrial pressure already occurring, isn't it? So is how it is related to the bronchial veins? Where bronchial veins actually they empty into, they drain into which particular part of the venous system? Bronchial veins. They drain the bronchioles, isn't it? Bronchial veins. Later, they drain into which particular venous system to enter back into the right heart. It has to come back to the right atrium and right ventricle, isn't it? All these to get oxygenated. Any idea? Or, the branchial veins will drain into azygos and hemiazygos veins, and then through the superior vena cava, they again enter into the right atrium. Now, what is happening to the right ventricle, right atrial pressures in these patients? Because of the back pressure effect. It is increased, isn't it? Right ventricular pressure, pulmonary hypertension later develops. So right ventricular pressures will increase, right atrial pressures will increase. So superior vena cava pressures will increase. So naturally, the pressures in the azygos, hemiazygos veins will increase. So naturally, the branchial veins will engorge. Once they engorge, they become thin-walled. Once they become thin-walled, patient having a cough, because they are highly prone for upper respiratory infections. Once there is an increase in intrathoracic pressure, these veins may rupture, and that may be the cause for, hemoptysis. So what is the other cause for hemoptysis?
Other causes?
No, other cause in these patients in mitral stenosis. Another cause, pulmonary infarction. They can also develop, pulmonary infarction that, it is not because of the left atrial thrombus. It is because the right atrial thrombus. Later, once there is so much of increase in back pressures, even the right atrial afterload increases. Right atrium may not be able to easily push its blood into the right ventricle. So there is stasis of blood in the right atrium also that can produce a thrombus, and the thrombus may get detached and then enter through pulmonary artery into the right ventricle pulmonary artery, and the pulmonary infarction can occur, and that can also produce hemoptysis. So just remember about the cause for hemoptysis. You may be asked in the exam in these patients. Okay, so the other thing you have written is hoarseness of voice. No history of hoarseness of voice. I think you should be able to talk about why did you ask this particular question?
Sir, due to increase the left atrial pressure, there is a pressure effect on a left pulmonary artery on a left recurrent laryngeal nerve, sir. So the patient develops hoarseness of voice and cough.
No, is it because the left pulmonary artery, or it's because the left atrium itself is enlarged?
Left atrium is enlarged, sir.
Yeah, left atrium is enlarged, and the recurrent laryngeal nerve left side is very close to the left atrium because it is arching around the arch of the aorta, isn't it? So that particular area, it is very close to the left atrium. So there can be a pressure application of left atrium over the left-sided recurrent laryngeal nerve, and it may have a palsy. And because of that palsy, why the patient should develop hoarseness? What else is paralyzed? Any movement of a particular thing is paralyzed. Movement of the vocal cord is paralyzed. Left vocal cord is paralyzed. So that is the reason why. That is why. What is this named after somebody, isn't it? It's called as some syndrome. Ortner syndrome. So another name also is there for this. It is called as cardiovocal syndrome. Cardiovocal syndrome. It's because the enlargement of the heart, the vocal cord paralysis has occurred. That's why it is also called as vocal syndrome. So history have taken. So then you have written about no history of chest pain. So what is the cause for chest pain in these patients with
because of the
mitral
right
stenosis?
ventricle hypertrophy and right ventricular strain?
Right ventricular hypertrophy, how it can produce chest
pain? Due to
pain?
the stitch of the right ventricle, it's a right ventricle strain.
No, is it just right ventricular strain? It is strain will be there. It will be straining. That is what you can see in the ECG. ST sagging, ST segment depressions will be there in right ventricular leads, V1, V2, because of the right ventricular strain. It will be straining to push blood into the pulmonary system because there is pulmonary vascular resistance has increased. But why chest pain? The chest pain will be like angina. It's a cardiac pain. Why they develop angina due to right ventricular problem? If it is hypertrophy, what happens to the right ventricular demand of oxygen? Once it is hypertrophied, its confidence has decreased, pressures have increased, isn't it? It is because the increase in demand and the supply may not be able to meet the demands. So once the supply demand imbalance occurs, there is angina occurs. So you should always think that these patients can develop chest pain, but late in their disease, not early in their disease. And chest pain can be due to right ventricular angina. It is not left ventricular angina, it's a right ventricular ischemia that can produce chest pain. Another important cause for chest pain, just now we discussed about pulmonary infarction. That also, but it will not be a like angina. It will be a continuous pain and acute pain and sudden onset and continuous pain will be there. That is slightly different when compared to anginal pain. So these two are the causes for chest pain in these patients. One more thing you have also written about dysphagia. No history of dysphagia. So what may be the cause for dysphagia in these patients?
An enlargement of the left atrium compressing over the esophagus. So that will cause
Okay.
dysphagia in patients.
Yes, that is another very important thing. Yes. And one thing is, I was telling you in the beginning only that everything what you will be asking or leading questions you'll be asking, isn't it? So in this particular patient, you should have asked, so what made her to come to the hospital? So you have written that because the dyspnea, she has come to the hospital. And what actually was told to her, where she has been admitted, which particular department she has been admitted. And, she must have undergone some investigations. And she must have been told by the doctors about particular, what disease she has. So these are the things. And what they have told her that, this may be required, this particular thing, like maybe a percutaneous procedure or even a valve replacement. So these things you have to elicit from the patient and then present. Very, very important, because for you, it will become very easy at the end, because patient herself is telling you that she has got a cardiac disease, isn't it? Many times, when the student presents, it will become very difficult for us to know whether the student is presenting a respiratory disease or a cardiac disease. So it will become very important, and you can always get more information from the history, and especially the patient literacy. Again, that is very important in the introducing the patient. What is the literacy of the patient? Because if the patient is literate, you can totally rely on the patient's history, one. The second thing is, the patient can even tell what drugs the patient is on. Like indirectly, you have told certain drugs the patient is on. Instead of that, the patient can name the drugs. You can know what drugs the patient is on and what procedures the patient has had before and what procedure the patient has been told to undergo. So all these things you will definitely know by presenting, because I told you there is a pre-anesthetic evaluation. It is not you are trying to diagnose something. So did you ask these things from the patient?
No, sir.
Where she has been admitted and what has been told to her?
No, sir.
Now that is very important, because she definitely should have been told that she has a cardiac disease. Probably she would have been told about cardiac disease when she was admitted during her pregnancy and delivery. When she was admitted in ICU, she must have been told, isn't it? So that is one very important thing. So you will get more information once you start asking them. And once you present the same thing, like suppose a literate patient is there, the literate patient will tell you that patient has got a mitral valvular heart disease. The same thing you can present. The patient is telling that the patient was told that the patient has mitral valvular heart disease and also has been told that patient may require to undergo these particular procedures and what drugs the patient is on. So it becomes very simple for you at the end, isn't it? So this, don't forget to ask why the patient has been admitted, what the patient has been told about. Okay, so that is one thing which you should always add in the history. For any particular comorbid condition, just try to inquire about these things. And another very important thing is the medication history should be a part of history of presenting illness. Don't keep the medication history to the end. Like you have kept the medication history to the end after family history, personal history, past history, after all those. Medication history is a present history, isn't it? What the patient is presently taking. That is the medication history, and that has got a lot of implications for us as anesthesiologists. For a person like a medicine postgraduate, it may not be so relevant for the history of presenting illness. But for us, it is very, very important. So you have to bring it to the history of presenting illness. For all cases, long cases when you are presenting. So in the history of presenting illness, let it be a part of history of presenting illness like medication history, and you start talking about what medications this patient is on. Now coming to that particular history only, the treatment history, you have said that patient is receiving IM injection every 3 weeks. So that is a very important part of your history to say patient has this particular cardiac problem as related to the rheumatic heart disease, isn't it? So what injection the patient may be receiving, Kaushik?
Sir, injection penicillin.
Penicillin injection. What penicillin the patient will be receiving once in three weeks?
Benzathine penicillin, sir.
Benzathine penicillin. What is the dose usually you'll be receiving? What dose of benzathine penicillin?
For less than 27 kgs, it's 6 lakh international units, sir.
Less
More
than
than 27.
40 kgs. Less than
12
40
lakh.
kgs.
12 lakh international.
Yeah, 6 lakhs and 12 lakhs, isn't it? 6 lakhs for less than 40 kgs and 12 lakhs for more than 40 kgs. So you see, all these questions, if you're answering very well, we will ask you. Because we think that you are not going to answer, and if you answer, definitely your marks will go up. So benzathine penicillin is a long-acting penicillin, isn't it? It's a penicillin G only, but benzathine penicillin G is a long-acting penicillin, and is usually given because you will be asking the question. Suppose if a literate patient, he will tell you. If illiterate patient, you may extract that. Usually, what is the color of this drug? You have seen benzathine penicillin? If you have seen, definitely you know. It is white color and it has to be reconstituted, and very difficult to reconstitute it. It won't dissolve easily. And another thing is you require a larger bore needle to inject. It won't pass through 23 gauge needle what you have routinely with your syringe. You may require about a 21 gauge needle, and even that also very difficult. It may get stuck. The needle may get blocked. So that is what, as medical officers, we have seen. We have given so many patients with this benzathine penicillin. A lot of difficulty will be there for benzathine penicillin. So another very important question you may be asked regarding this: the preventive for what? Prevention for infective endocarditis or prevention for streptococcal infections?
Or rheumatic fever, streptococcal infection.
Yes, mainly for prevention of streptococcal infection. So how long it is given?
Sir, will you from the answer 10 years of period you want to give, sir, or
okay,
until 40 years of age? Which one will come first? Will you, sir?
No, because there are two kinds of patients. One patient only having rheumatic fever history, but not developed any cardiac problems. Another patient is there who has a rheumatic fever and also has developed the valvular heart disease. Two groups of patients, isn't it? So for the first group, as you said, it is for 10 years from the time the patient has developed rheumatic fever till 21 years of age. So you are preventing even the cardiac involvement. We are continuously giving further infections, you are preventing further antigen antibody reactions, you are preventing further inflammatory problems, you are preventing. So another patient who has already developed valvular involvement, for him, how long you are going to give?
A lifelong, sir.
No, it is up to 40 years.
40 years of
Or
age.
it is like, from the time the patient has developed the symptoms of rheumatic fever for 10 years or 40 years, which is later. Suppose if a patient has developed at the age of, say, 15 years, rheumatic fever, and also he has developed a valvular heart disease. So only 10 years means 25 years it will be. No, if he has already developed valvular heart disease, till he becomes 40. Okay, another patient who has developed rheumatic fever and cardiac involvement, say, first time he has developed all these things at the age of 32. Now till another 10 years, whichever is later. So that is another common question that you will be asked, because these are the questions which are simple questions mainly the medicine questions, of course, but as anesthesiologist, you are supposed to know about these questions also. So the other things, so that adds on to your positive thing regarding the rheumatic fever. So then you have written the patient is taking some tablet for 5 days in a week, and then 2 days is told not to continue. So what may be this particular tablet?
Digoxin, sir.
Okay, Shruti, that is definitely Digoxin. And why this patient can be on Digoxin?
To control the heart rate, sir.
Yeah, because what are the indications for Digoxin as such for cardiac disease patients? One is atrial fibrillation for control of heart rate.
Control of heart rate.
Okay, what is the other indication?
To reduce the pulmonary arterial hypertension, sir.
No, it does not have much effect on that, mainly for cardiac failure patients. So these two, because Digoxin has got two effects. One is it has got a vagotonic effect. It also has got an inotropic effect, isn't it? So by its inotropic effect, it helps in patients with cardiac failure. By its vagotonic effect, by effect on actually the AV node. So by delaying the propagation across the AV node, so it helps in patients with atrial fibrillation. So atrial fibrillation and cardiac failure of two indications. In this patient, it is mainly for control of heart rate as far as the atrial fibrillation is concerned. Now, coming to Digoxin itself, so why it is being stopped for 2 days? Why it is not continued in all the 7 days? Why not all 7 days? Majority of the drugs what we usually give, we don't stop in between, isn't it? Like, for example, beta blockers, the patient can be on beta blockers. So usually we continue to give, we don't stop. So why Digoxin is typically it is stopped after say 5 days and 2 days you're stopping. What is the reason? One reason is, it is long-acting drug. Half-life is more than 48 hours. And second reason is it has got cumulative effect. It accumulates in the body. So what if it accumulates in the body? So like amiodarone has got a long half-life of 29 days, but you don't stop amiodarone, you continue, isn't it? So these are not the reasons for stopping, but it has got a narrow therapeutic index. Narrow therapeutic index. What is therapeutic index?
The range of them. Sir.
So therapeutic index is the ratio of therapeutic concentration divided by lethal concentration. Therapeutic concentration and lethal concentration. If it is wide, the drug is very safe. If it is very narrow means therapeutic concentration, lethal concentration are very narrow, then the drug is not very safe. Digoxin has got a narrow therapeutic concentration because, its therapeutic concentration in the blood is just about 1 to 2 nanomoles per ml. Nanograms per ml. 1 to 2 nanograms per ml is therapeutic concentration, and more than 3 nanograms per ml becomes a lethal concentration. It is such a narrow therapeutic index. So now you just imagine it is accumulating and the blood concentration is increasing. So once it increases, the patient will definitely develop lethal problems, isn't it? Digoxin is not a very safe drug. That is the reason, in order to reduce the cumulative effect of Digoxin, you are going to continue it only for 5 days and you're going to stop for 2 days. So very important thing for you to know regarding for exam purpose. And another thing is, if the patient is on any drug for that matter, we always think what any special investigations we have to do if the patient is on this particular drug. Second thing is whether to continue this drug particularly on the day of surgery. If we continue this particular drug on the day of surgery, how it is going to interact with our anesthetic drugs. So these 3 questions you have to answer, isn't it? So if I'm using Digoxin, any particular investigation, Shruti, I have to do?
Serum potassium levels.
Yeah, potassium levels. Why potassium levels are important if the patient is on digoxin?
Hyperkalemia. It causes hyperkalemia, sir.
It will not by itself produce hyperkalemia because it is acting mainly where? It is acting on phase 3 to phase 4 action potential, where it prevents, the potassium entry. That is sodium potassium ATPase is inhibited so that the sodium cannot come out of the cell and potassium cannot enter the cell. So sodium gets, replaced with calcium, and calcium will start entering into the cell. That's how the inotropy will increase. That is how digoxin acts at the action potential, isn't it? It doesn't produce hyperkalemia as such. It may prevent potassium to enter back. But the problem is any hypokalemia can produce increased incidence of digoxin toxicity. So you have to avoid in a patient who is taking digoxin, hypokalemia. So that is the reason why you have to get a potassium estimation done. And second thing is, should you continue digoxin on the day of surgery or you don't continue on the day of surgery?
Yes, sir. We continue on the day of surgery, sir.
For all patients? Suppose I told there are two indications for digoxin. One is cardiac failure, another is atrial fibrillation, isn't it? If the patient is taking digoxin for cardiac failure, control of cardiac failure, second is control of ventricular response to atrial stimuli. When you want to stop or when you want to continue. Patient is posted for two kinds of surgery, cardiac surgeries and non-cardiac surgery. Any idea? See, one thing is that if the patient is posted for non-cardiac surgery, whether the patient is on digoxin for control of cardiac failure or control of the ventricular response, you continue on the day of surgery. If the patient is posted for cardiac surgeries on digoxin, if the patient is on digoxin for control of cardiac failure, you stop 48 hours before. Because one thing you should realize, digoxin produces increased sensitization of the myocardium. Because you know that it acts on the action potential phase 4. So during cardiac surgery, there can be release of a lot of problems as far as dysrhythmias are concerned, because they are handling the heart. That is why 2 days before you stop digoxin, if the patient is on digoxin for cardiac failure and not for control of atrial fibrillation, and give complete rest, bed rest to the patient for 2 days, because failure is in failure, isn't it? So you have stopped the inotropic drug also. So that is one thing. And if the patient is taking digoxin for control of his atrial fibrillation, then you continue even if it is cardiac surgery or non-cardiac surgery. So this you be very clear when to continue, when to stop. So another investigation we can also do is nowadays the digoxin serum digoxin levels you can also get. Many of the laboratories are giving you serum digoxin levels. That also you can get, because to know whether the serum levels are in the therapeutic range or they have increased. And if the patient is on digoxin, what history you will be taking to know whether the patient has gone in for digoxin toxicity? What is the first symptom of digoxin toxicity?
Sir, in ECG, you can see the...
No, I'm not talking about ECG. Symptom. Because you may not get ECG, isn't it, in exam? So symptom and signs of digoxin toxicity. Because once you mention a particular drug the patient is on, a lot of questions will be asked regarding that particular drug. Because the first symptom of digoxin toxicity is nausea, vomiting. Anorexia, nausea, vomiting. This is very important, and you may have to ask about this particular patient, whether after starting digoxin and later, after some days, the patient has developed anorexia, nausea, vomiting. So this is very important. And another thing you will have to differentiate also, because the patient is in failure. Patient also will have anorexia, nausea, vomiting is very common, especially right heart failure, because the back pressure effects. So there is more congestion of the GI tract. Patient will have all these symptoms, including congestion of the liver, liver enlargement. So, but digoxin by itself, suppose the patient is not in failure and he is on digoxin and of late he has developed this. So you may have to think that the patient may be going in for digoxin toxicity. So that is one very important symptom you'll have to inquire with. The other thing is, so which is the most common dysrhythmia the patient can develop with because of digoxin. The first dysrhythmias, the initial, the patients can develop a certain amount of dysrhythmias, which you can, know, or at least can think by palpating the pulse. Most common dysrhythmia the patient can develop is ventricular premature contractions. And especially the patient can develop bigeminy or trigeminy because of digoxin. That is the first important early signs of digoxin toxicity. Of course, as Kaushik was mentioning, in the ECG, you can make out if the patient is on digoxin, what is called as digoxin effect. That is not a sign of digoxin toxicity, but you can just see the, the ECG, and you can even tell that patient may be on digoxin. What is that sign in the ECG? If the patient is...
Reverse tick sign, sir. Reverse tick sign.
Yeah, reverse or mirror image tick sign. What is that reverse image tick sign? Very good. So what is that?
The T wave inversion, sir, in ECG.
T wave inversions or
Sagging of ST segment.
ST depression with ST sagging with a small T wave. With a small T wave, especially the second limb of the T is very, very short. So that's why you have a mirror image tick mark. Tick mark is like this, isn't it? So mirror image tick mark. So the opposite of the tick mark. So that is called as digoxin effect. So other than the bigeminy, trigeminy, or VPCs, what else is the digoxin toxicity early sign in the ECG?
So the patient may have a first degree and second degree heart block, sir.
Yes, very important is first degree AV block. So prolonged PR interval. So once there is a prolonged PR interval, you have to be very careful with digoxin, continuing digoxin, because the patient may be going in for digoxin toxicity. Okay, that is another very important thing. The next thing is, if the patient is on digoxin, you said that you are going to continue for non-cardiac surgery, whether it is for heart failure or whether it is for atrial fibrillation. Shruti, suppose if I continue digoxin, any drug interactions?
Yes, sir, with succinyl choline, sir.
Pardon?
There's a drug interaction with succinyl choline. There's a possibility of digoxin toxicity when used with succinyl choline, sir.
Digoxin toxicity or something else? What is the effect of succinyl choline on the heart rate?
Tachycardia, sir.
Bradycardia, very good.
Yes.
So, because it is two molecules of acetylcholine, isn't it? Succinyl choline is two molecules of acetyl. By its muscarinic effect on the SA node, it produces, and the AV node, it produces bradycardia. Now, it is also on digoxin, which is also suppressing the SA nodal activity and AV nodal activity. So together
it will cause a profound effects of digoxin.
Yeah, profound bradycardia, not digoxin toxicity, can produce more profound bradycardia, also along with the inhalation anesthetic agents, because majority of the inhalation anesthetic agents also can have some effect on the conduction system. Especially it used to be very common with halothane, because halothane used to produce quite a bit of suppression of the AV nodal conduction. So that's how, many of the times you have to be very careful when you are continuing with digoxin. Okay, that is one more thing. The other drug the patient is on is, the diuretics, because you have just written that the patient maybe is given some drug which is increasing his urination, isn't it? So why diuretics are being given for this patient, and what diuretics are usually given for this patient?
Because the patient may be on pulmonary edema, sir, volume status. So for that, we'll give the diuretics, sir. Usually, we'll give loop diuretics, sir, furosemide.
No, maybe to reduce the pulmonary congestion, isn't it? To reduce the preload of the right ventricle and also pulmonary congestion. That is what is producing all the symptoms of for this patient. So you may have to reduce the pulmonary congestion. So one way of reducing the pulmonary congestion is reducing the preload. So you're going to reduce the preload by giving diuretics. So yes, you have to give a more potent diuretic. More potent diuretic is furosemide. But one problem with furosemide and digoxin combination. Any problem? Already we have discussed. what furosemide is going to produce as far as electrolytes are concerned?
Hypokalemia, sir.
Hypokalemia. Already we just now discussed if the patient is on digoxin, also on furosemide, there is always a possibility that the patient may develop digoxin toxicity because of the hypokalemia, isn't it? So they usually don't go together, but you want to add any other drug along with furosemide to reduce the problem of hypokalemia? You can also add another, drug like potassium-sparing diuretic.
Spironolactone.
Yeah, spironolactone with furosemide. Majority of these patients can be on furosemide with spironolactone, or otherwise, in olden days, when I was a student, I used to see routinely that the patients used to be on furosemide plus potassium oral supplementation when the patients were on digoxin. Now that also can be a possibility, and you may have to ask any syrup is being given by the patient for the patient, or the patient may be on potassium sparing diuretics, isn't it? So if the patient is on potassium sparing diuretics, there is always a possibility of hyperkalemia also can occur. So that also you have to keep it in mind. Okay, if the patient is on diuretics, so what should we do? Should we continue diuretics on the day of surgery, or what investigations you have to do?
Sir, we can continue the diuretics on day of surgery, sir.
Any particular investigations, first of all?
Serum electrolytes we want to repeat on the day of surgery.
Serum electrolytes. Any particular, examination you want to do when you are doing an examination of the patient?
We have to rule out hypovolemia, sir.
Hypovolemia, very good. So it can produce hypovolemia and, alteration in the electrolytes. So how do you rule out hypovolemia with your examination?
We can check the pulse.
Pulse, in these patients already it's a low volume pulse. Low cardiac output status.
Any signs of dehydration, sir?
Dehydration, they may not, over dehydration, they may not develop as such. Like skin turgor, all those things, altered sensorium, all those things may not. Frank, overt dehydration symptoms or signs they may not have. So one very simple examination, when you're, I'll give you a clue, when you're taking blood pressure, anything which you can make out whether the patient may have.
If the diastolic blood pressure is very low, you can say that.
No. Okay, you take the blood pressure in lying down and standing. Now you must have got some clue. Why should you measure the blood pressure in both lying down and standing when the patient is on diuretics? Or many of the hypertensives also.
In sitting position, due to gravity, there is a...
I'm not talking about sitting, standing. Lying down and standing. Suppose if the patient is hypovolemic, what happens? The difference in blood pressures, especially the systolic pressure.
Sir, if the patient is hypovolemic, on standing, from standing to supine BP, there is a variation of systolic blood pressure, sir, more than 20%.
Not 20%, it is more than 20 millimeters, or some books always give more than 30 millimeters of difference in the systolic pressure. That is orthostatic hypotension. What we call it as orthostatic hypotension is very common if the patient has hypovolemia. So this you have to measure because, I've gone through your examination findings. You have not written, you have taken lying down and standing blood pressure. So that is one thing as an anesthesiologist, you should always measure both lying down blood pressure and the standing blood pressure, and to rule out any orthostatic hypotension. And very common if these patients are on vasodilators or on diuretics, or patient already having because of other reasons. For example, now you always tell these patients to take oral fluids till 2 hours before surgery. But the surgeon tells not to take anything from the night onwards. No fluids, no solids. Or you have experienced that, isn't it? Including your surgery PGs will definitely tell that. And majority of the students will listen to surgical people and don't listen to you. So what will happen? The patient may come with hypovolemic condition, isn't it? So again, on the morning of surgery, before you take the patient inside, You measure the patient's blood pressure in the lying down and standing blood pressure and rule out hypovolemia, rule out orthostatic hypotension. And again, the patient has, diabetic autonomic neuropathy. Again, this is a problem. So there also you will be measuring. So in this patient, if the patient is on diuretics, there is a chance that the patient may have hypovolemia. So Kaushik, if the patient has hypovolemia, you have not done this test of orthostatic hypotension, whether the patient has or not. And in the exam, you will not be given any kind of investigations for you to know whether there is alteration in the electrolytes are there, any fluid imbalance is there. Nothing will be given, isn't it? No, you will have to assess the patient by your examination. You have forgotten to assess. And what is the importance of this? Suppose the patient has hypovolemia.
Sir,
Any
the patient
problem
is,
for managing the patient?
sir, the patient's hypovolemia, we are given the diuretics is still more detrimental, sir. The patient's arterial increase, sir. Reflex tachycardia will be there, sir.
No. If the patient in general, I'm asking, if the patient has come to your OT, inside the OT, you have taken up with the patient having hypovolemia undetected. What happens if you give propofol? What happens if you use inhalation anesthetic agents for these patients? What happens if you change their position? If you do an head-up lap cholecystectomy, the patient is posted for, you are putting the patient into head-up position. You are giving an central uraxial blocks like, epidural, like even spinal anesthesia. What is the effect in these patients if the patient is having hypovolemia?
Sir, sudden fall in BP, sir, blood pressure.
Yeah, sudden exaggerated fall of blood pressure, and especially in older patients, they may even go for arrest on the table. If you just give propofol, tapentone, or you give spinal anesthesia, how many patients you have had severe fall of blood pressure after giving your or inducing the patient or inducing them with spinal anesthesia? Isn't it very common because many of these patients may have hypovolemia. And once the patient is on digoxin, on loop diuretics, they are very potent diuretics, and the patient may come with hypovolemia. So that is why, your examination should be lying down blood pressure, and standing blood pressure is very important. And you just say, and the next thing the examiner is going to ask you when you say lying down blood pressure is this small, standing blood pressure is this small, why did you measure? So you have to tell that patient is on hypovolemia, the patient is on diuretics. Probability of hypovolemia is very high. I want to rule out hypovolemia. Isn't a very simple examination finding. So that is one thing. Now you said that you want to continue on the day of surgery. Diuretics, very potent diuretics, loop diuretics. Should we continue or should we stop? Because now you are telling that they can produce hypovolemia and electrolyte imbalance. When you know that they can produce these problems, and you are not going to measure the electrolytes just before you take up for surgery. Do you measure? You will have the previous days, investigations. And you are still continuing on the day of surgery also. On the day of surgery, you can develop electrolyte imbalance.
Yes, sir.
If you continue. So should you continue or should you stop?
Please stop, sir.
Now you have changed your answer, isn't it? So you should stop. So especially very potent diuretics like loop diuretics. When do you want to stop? Is it on the day of surgery or at least 24 to 48 hours before?
24 to 48 hours.
Ideal would be about 2 days, 48 hours before. Because you allow the patient to have normovolemia or euvolemic status, and also the electrolytes when the patients are taken up on the day of surgery. So ideal is you have to stop these drugs at least 2 days before. So another very common drug, these patients can be on anticoagulants. We'll discuss about the anticoagulants when we discuss about different case scenarios when we come to. So any other drug the patient is on?
Only these
Two drugs, isn't it? Digoxin and... now, this patient was given these drugs much before, or now after admitted into the hospital, the patient is getting these drugs?
So much before, sir.
She's taking before also.
Yes, sir. Yes. Sir.
Now, after getting admitted to the hospital, what drugs has been changed? So because that is the current medication history. That is more important for us. And these drugs, the patient may be continuing. You can always ask whether you are continuing these drugs even now. The second thing is patient might have been given other drugs also. What other drugs the patient might have been given?
Sir, patient may be given a rate controlling with sir, metoprolol.
No, digoxin itself is there, rate controlling. So suppose if it has not been controlled with digoxin, definitely a beta blocker, like as you said, metoprolol or atenolol, long-acting drug, they might have introduced. Okay, that is one of the drugs the patient can be on. Okay, then
Or
amiodarone. Patient, suppose if when you do you give amiodarone for this patient as such? What does the amiodarone, the effect of amiodarone on atrial fibrillation? Is it rate controlling drug or a rhythm controlling drug?
Rhythm controlling drug, sir, anti-arrhythmic, sir.
It's ideally used as a rhythm control. So there is no point in rhythm control in this patient, isn't it? Because again, it will revert back to atrial fibrillation. Even if the patient, you control or bring the patient to sinus rhythm, because the probability, because the left atrium is enlarged, so you cannot do anything. Okay, suppose let us think that the patient is on a beta blocker. So should you continue on the day of surgery, or you will withhold on the day of surgery?
We'll continue on the day of surgery, sir. Beta blocker.
Beta blocker, you would continue on the day of surgery. What happens if you stop beta blockers about 2 to 3 hours before, 2 to 3 days before surgery?
Sir, if we stop the beta blocker, the heart rate will increase, sir. So the tachycardia is detrimental to the valvular stenotic patient.
Correct.
Sir.
You should never, because the withdrawal effect. There can be a rebound effect, isn't it? Why a rebound effect with beta blockers? What is the reason? Why they can have a rebound increase in heart rate? Any particular reason? Because whenever these patients, or beta blockers are, antagonists to beta receptors, isn't it? So when the patient is taking an antagonist to these receptors, body will try to increase the number of receptors. Body will not keep quiet, isn't it? So because there would have been number of receptors would have been increased, and suddenly these receptors will not come down once you stop beta blockers. So suddenly if you stop, the catecholamines are going to act on these increased number of receptors, and that can produce a sudden increase in the blood pressure as well as increase in the heart rate, which is called as the upregulation of the receptors, isn't it? So that is the upregulation. So you don't stop beta blockers. We can just discuss on beta blockers about half an hour we can discuss. So because of lack of time, we'll not discuss about beta blockers. The other things about, you have also written about the previous history of recurrent fever and, throat infection. Isn't it? So once you tell that, you may be asked about Jones criteria.
Yes, sir.
So can you just mention about Jones criteria?
Major and minor criteria, sir.
That's very good. Major and minor criteria.
In major, there is myocarditis, migratory polyarthritis, subcutaneous nodule, Sydenham's chorea, and erythema marginatum, sir.
Okay.
In minor criteria, there is fever, increased CRP, ESR, polyarthralgia.
First you tell about the symptoms, like fever one.
Fever, polyarthralgia.
Polyarthralgia. Correct. Okay.
Prolonged PR interval.
Yeah, ECG prolonged PR interval.
Increase ESR CRP, and ASO titer is more than 300. Sir.
Yeah, ASLO titer will be high. One more is leukocytosis. So these are the minor criteria. So how many major criteria or minor criteria to be there to diagnose rheumatic fever?
2 major criteria or 1 major and 2 minor criteria. Sir.
Minor criteria have to be there. And when this was proposed by Jones? Is it recent or very long back? It was proposed in 1944. Oh, yeah, has there been any update on this?
Yes, sir.
When it has been modified, recent modification.
Recent modification. So high risk group and low risk group, sir.
Yeah, that is in 2015 by AHA,
Sir.
Yes, sir.
American Heart Association and ACC. They have modified in 2015. Very good. So low risk patient and high risk
risk
patients for diagnosis. Low risk patients are not Asian patients. The low risk patients are the Western patients, developed countries, isn't it? They are at low risk of developing rheumatic fever. What are the criteria for low risk? All these criteria, what you said, are for low risk patients, isn't it? For high risk patients, what are the change in the criteria? That is what is modification in 2015. For low risk patients, all these criteria have to be there. Like, as you said, polyarthritis, carditis, Sydenham's chorea, erythema marginatum, subcutaneous nodules, and many of these minor criteria. And 2 major, 1 minor. For high risk patients like Asian community, we are all at high risk of developing rheumatic fever, isn't it? So what they have done is, polyarthritis has been changed to even monoarthritis is enough as a major criteria.
Yes, sir.
Monoarthritis, that is one of the change. Second change is in the minor criteria, there need not be polyarthralgia. Monoarthralgia is also enough. That is another one. It's another thing as far as the ESR is concerned. In major criteria, in the minor criteria for low risk, it has to be more than 30 millimeter per hour. Whereas for high risk patients, more than 20 is enough to diagnose. Then one more thing, you talked about ASLO titer. For low risk, it has to be more than 300 TOD units. For high risk, more than 200 TOD units is enough. So it is again very important for exams, because many of the examiners are very fond of asking you about the Jones criteria, and especially the modified Jones criteria is again very important. So another question is that you have said about the abstract history. You have not written when she had this child. How long back? Isn't it? You have just written that she has one child, and during the delivery, she had this problem of sudden increase in the breathlessness. She was even admitted to the ICU for 2 days or 3 days. So actually, when it happened, because that is again important, because from that time, already she may be having the problem, isn't it? Now she is 32-year-old. So when did she have this delivery? Did you ask? You have not asked, isn't it? So suppose if the same thing is asked to you in the exam by the examiner, suppose you have not taken that history. Okay, use your common sense and just tell something there. You just tell when she was 24-year-old. That is about 8 years back. You have forgotten to ask, okay. But I keep telling my students also, just use your common sense. Don't show a blank face. Then, it shows that you have not asked and there can be a negative marks for you, isn't it? So you just tell, 8 years back, sir, when she was 24-year-old. But you have to be very relaxed for that to be able to answer like that, isn't it? That is one thing. And second thing is, at that time only she would have been told about this problem, the cardiac problem. And she is also on penicillin. Since how long she is on penicillin? That I don't know whether you have written.
So from 16 years of age, sir.
Yeah, since for the past 16 years, that
Yes,
would have been diagnosed with this 16 years back. Isn't it? Now she is 32-year-old. So all those time periods are very important when you are presenting. And she must have been told. Suppose if she has been told and you tell in the history itself, she was told that she has a problem in or one of the valves, and also she has been told that she may has to undergo a procedure, percutaneous procedure. So it will solve many of your questions at the end when you are presenting it as a rheumatic heart disease. You know that the history of upper respiratory infections, that is throat infection, previous history of fever, arthralgia, that you would have said. And in penicillin injections, again, rheumatic fever and rheumatic problem. And if you say she also was told that she has a cardiac problem and a valve problem, and if she was a literate, she would even tell you mitral stenosis, isn't it? So everything will be solved. Okay, so it is, I think, exactly 7 o'clock. We will stop at this. We'll continue tomorrow, and then we'll try to finish in tomorrow 2 hours. The examinations, pathophysiology, and the management. We'll have to finish. Because that's why when Mukhtiar asked me, sir, one day for mitral stenosis, next day we'll go for some other case. I said, I'll not be able to finish in one day mitral stenosis. I require 2 days, that is at least 4 hours, minimum 4 hours. Oh, I hope you are, it's okay. We'll continue tomorrow, then we'll try to finish. Again, you prepare, read and come. And if you have any doubts, first thing tomorrow, what we do for a few minutes, we'll know about your doubts. Until now, what we have discussed, you may have certain doubts. So we'll discuss about those doubts. That is what I do every day for my students. The first few minutes, always, if they have any doubts, I'll be asking them. I'll be discussing all those doubts. I'll be clearing those doubts if I know the answer. Then we will proceed with our regular discussion. Okay. Thank you so much. You have done very well. Both of you really have read. I had not expected this much from Mahatma Gandhi students because I've been an examiner to Mahatma Gandhi many times.
Yes, sir.
Yes, of course. Many years back. I know about their performance. Hemant can tell, definitely will also with me about their performance long back. Now I think things are changing. Okay, thank you. We'll continue tomorrow.
Thank you so much, sir. Can you hear me, sir?
Yeah, I can hear you.
Yes, sir. Yes, sir. You have been and you have seen the students.
Yeah, definitely. No, there's a lot of change. Both Shruti and Kaushik are answering very well. So I think the students' performance this time during their exams will be better. Definitely.
It's going to be just because of you, sir.
No, again, that also my teaching also will help them. So if all of the other students are also listening, anyway, it is going to be recorded and they can listen to these things afterwards. And one more thing I want to tell you, because all these every day what I'm teaching for my students have been recorded. So I think if you request our students, they can give you all the recordings of all these number of days. Almost, I think from April 1st, I am teaching them. Can you imagine April, May, June, July, and now August is almost ending. So the students can get all the recordings. If they have time, they can listen. So it may help them, definitely.
Yes, sir. Thank you so much, sir. Engaging the students for 2 hours continuously, there is the art you are having, sir. I think
we have not. I forcefully ended this discussion of the history. So still I could have continued with the history.
Tomorrow we'll start again.
Yeah,
and we'll just try to do something, sir.
Examination and management of the case.
Sure, sir. Okay, sir. We'll end the meeting, sir.
Yeah, we will end the meeting. Tomorrow we will join. And you can also ask the other students also if they have any doubts. Shruti and Kaushik can ask them and note down the doubts of your fellow students. And briefly, we can discuss those doubts in the first particular 10 minutes or so, and then we can start with our regular discussion.
Okay, thank you so much.
Thank you, sir.
Thank you, sir.
Okay, right.